Hey everyone, Phil Plisky here from FMS. I'm with one of our functional movement systems instructors, Jenna Gourlay. Thanks everyone for all the feedback on these videos. We've had tons of great questions. Jenna, is there a question or questions that really kind of stood out to you?
Yeah, one question actually stood out in particular because I think it's something that a lot of people struggle with, especially early on in using the SFMA, and then probably some even more seasoned users. And it was about the extension breakout, right? So let's say you're doing a top tier and the multi-segmental extension pattern is painful. And this is a patient with low back pain. Now, our principles would tell us to go after the non-painful patterns first, but what if you're doing your evaluation and multi-segmental extension is painful, but you're wondering, what about repeated movements?
Oh yeah, absolutely. This is kind of where real world really hits. Several principles really come to mind is, first of all, do no harm with our patients. Secondly, let's manage chemical pain and inflammation first. That becomes a priority. And really third, we're still going to break out those painful patterns. And I'll start with that one first. Breaking out those painful patterns, you might find that actually maybe they have a T-spine limitation, and when they go down to those lower postures, extension is no longer painful, right? And that happens frequently. So that's one case scenario. So it actually makes it even more important to break that person out. Secondly, there's a lot of great evidence that mechanical diagnosis and treatment, or known as McKenzie therapy, for low back pain can be effective when someone centralizes and peripheralizes. So being sure that we get that person in the right category is super important. And Dr. Kiesel and Matzel in the low back pain course, they really talk about this really well, about how to categorize the person with low back pain and how to get them the right treatment that they need initially along with the SFMA. So it's not a disregard of the evidence, it's incorporating the evidence.
Okay, and so when it comes to kind of integrating those two different approaches or those two similar approaches that go together, are there any things or mistakes or things that you see people do that they could probably do better in order to make that integration a little bit better?
I think probably the number one thing I see is people who, and they've done this actually in research studies, unfortunately, where they'll do 10 repetitions of extension and 10 repetitions of flexion and determine that they are peripheralizing or centralizing or not based on that. And that's really not true to the mechanical diagnosis and treatment system, where you would actually do repeated movements, multiple sets, multiple reps in multiple postures. So you're all going to do it, standing, sitting, prone, supine. So to get an idea, be sure that if that person has pain down their leg, that you are certain that they don't peripheralize or centralize. Once you're certain of that, they're no longer in that category. And, now the SFMA becomes even more of a priority. But it's really key and really important to use the SFMA breakouts, even at that early stage, so you know what's going on.
Yeah, that definitely helps.
Fantastic. Good deal. Well, keep the questions coming. We love answering them. We love interacting with you all. So please don't hesitate to shoot a question, and we'll be glad to answer it.
Awesome.
Hey guys, if you like the video, definitely hit the thumbs up. And if you want to stay informed, hit the bell so we can notify you anytime we put up new videos. And of course, any questions or comments, put those at the end. We'll certainly be checking them out and trying to respond. Thanks so much. And remember, always move well and then move often.